Hi, this is Ben. Now let's go through some of the causes of acidosis and alkalosis. Let's first start off by looking at acidemia, which is defined as a blood pH of less than 7.35. What are the two main causes of an acidemia? That's right, either a respiratory or a metabolic acidosis. Before we get any further, let's first define some normal values for PCO2 and bicarb. This is important because deviations from these norms will give us a clue to what is happening physiologically. What is a normal PCO2 or partial pressure of carbon dioxide in the blood? That's right, it ranges anywhere from 36 to 44 millimeters of mercury. And what is a normal bicarb level? That's right, it ranges from 20 to 28 milliequivalents per liter. If the PCO2 is greater than 44, then we know that this is a respiratory acidosis because carbon dioxide is being retained. This is caused by anything that causes hypoventilation, such as airway obstruction, acute lung disease, chronic lung disease like COPD, opiates, sedatives, or weakening of the respiratory muscles, as seen in ALS or amyotrophic lateral sclerosis. Now, what if the bicarb is less than 20? Then we know that the acidemia is caused by a metabolic process because bicarb is being consumed as a buffer. In order to delineate the potential causes of a metabolic acidosis, we first need to check the anion gap. Do you remember how to calculate this? Correct. It's the sodium concentration minus the sum of the serum chloride and bicarb concentrations. And what should a normal anion gap be? A normal anion gap is defined as between 8 and 12 milliequivalents per liter. An increase above this tells us that there are additional anions in the patient's blood. This is important because these anions can be derived from acids that have donated their hydrogen ions to cause a decrease in the pH. Causes of an increased anion gap metabolic acidosis can be remembered with the following mnemonic: mud piles. This stands for methanol, which forms formic acid, uremia, diabetic ketoacidosis, propylene glycol, iron tablets or isoniazid, lactic acidosis, ethylene glycol, which forms oxalic acid, and salicylates. This list is incredibly high yield and will certainly appear on some, if not all, your exams on test day. Commit these causes of anion gap metabolic acidosis to memory. Now, if the patient has a normal anion gap but still has a metabolic acidosis, then the causes can be remembered by the mnemonic hard ass. This stands for hyperalimentation, Addison's disease, renal tubular acidosis, diarrhea, acetazolamide, which is a carbonic anhydrase inhibitor, spironolactone, which is an aldosterone antagonist, and saline infusion. Now, why does diarrhea cause a normal anion gap acidosis? Since both sodium and bicarbonate are lost in the stool, the anion gap will not change. And since bicarb is being lost, there is an acidosis that will develop. Out of this list, the two that will most likely show up on your test are diarrhea and renal tubular acidosis, so be sure to go back and review these. Now let's look at the causes of an alkalemia, which is defined as a blood pH above 7.45. What are the two main causes of an alkalemia? That's right, either a respiratory or a metabolic alkalosis. If the PCO2 is less than 36, then the alkalemia is caused by respiratory alkalosis. This is the result of hyperventilation and a loss of carbon dioxide from the lungs. This can be caused by hysteria, hypoxia at high altitudes, a lung tumor, or during a pulmonary embolism where the patient will increase ventilation in an attempt to increase oxygen saturation. Salicylates can also cause hyperventilation because they increase the respiratory drive. Now, what if the bicarb level is greater than 28? This means that this is a metabolic alkalosis, which is caused by an excess amount of bicarb or a loss of hydrogen ions. What are some causes of metabolic alkalosis that you can think of? Well, vomiting because of the loss of hydrochloric acid, and hyperaldosteronism because of an increased hydrogen ion secretion in the collecting tubule. Metabolic alkalosis can also be caused by loop diuretics and antacid use. Here's also a quick table for your reference to go over these in a more quantitative form. Now let's work through a quick problem. A patient comes in because of a morphine overdose. You check his arterial blood gas and his pH is 7.25 with a PCO2 of 60. What is his primary acid-base disturbance? In order to figure this out, let's follow the following algorithm. First, let's look at pH. Since it's less than 7.35, he has an acidemia. Now that we know it's an acidemia, we have to figure out if it's metabolic or respiratory. Since CO2 functions like an acid, a high CO2 level would point towards a respiratory acidosis as the primary disturbance. The patient's PCO2 is 60, so it is high. And if you look down the list, you see opiates listed as a cause of respiratory acidosis, which makes sense. So this patient has a respiratory acidosis. Now let's try a mini case. A 65-year-old alcoholic presents to the ED unconscious. When you talk to his wife, you find out that he drank wood alcohol, or methanol, because he ran out of vodka. What would you expect his blood pH, bicarb, carbon dioxide, and anion gap to be? In order to answer this question, you need to know that methanol causes a metabolic acidosis because it gets converted to formic acid in the liver. This means that the patient would have an acidemia with a pH of less than 7.35. A low bicarb, since metabolic acidosis is caused by a lowered HCO3. Low CO2 levels due to hyperventilation and respiratory compensation. And an elevated anion gap, since formic acid will produce formate, which is an anion. And how do you treat methanol overdose? Well, the two most common ways would be either ethanol therapy or hemodialysis. Now it's time for a flash quiz. What is the primary acid-base disturbance when the arterial pH is greater than 7.4 and the partial pressure of carbon dioxide level is greater than 40 millimeters of mercury? Correct. That'll be a metabolic alkalosis. The pH is greater than 7.4, so we know it's an alkalosis. If the partial pressure of CO2 is greater than 40 millimeters of mercury, then we know it's not a respiratory alkalosis because a PCO2 greater than 40 would begin to point towards an acidosis. Therefore, the PCO2 greater than 40 millimeters of mercury is a compensation and not the primary disturbance. The primary disturbance is a metabolic alkalosis. Now for a quick test yourself. A 6-month-old girl is brought to the emergency department by her mother after ingesting a bottle of unmarked pills from the family medicine cabinet. On examination, the child appears agitated and tachypnic. Urgent blood chemistry measurements are taken and reveal the following: a sodium of 143, potassium of 4.0, a chloride of 104, a bicarb of 19, and a pH of 7.28. Which of the following medications did this patient most likely ingest? The correct answer is C. This patient is suffering from an acidosis because the pH is 7.28, and we know that it's metabolic because the bicarb is 19. When calculating the anion gap, we subtract 123 from 143. This is the sodium minus the chloride and bicarb. This gives us an anion gap of 20, which is elevated. Therefore, we know that the patient has an elevated anion gap metabolic acidosis. The only answer from these choices that can cause this is iron supplements. A is not correct because although aldosterone increases protein excretion and inhibiting aldosterone would cause a metabolic acidosis, the acidosis would have a normal anionic gap. B is not correct because antacids cause metabolic alkalosis, not acidosis. They are anti-acids. D is not correct because loop diuretics cause metabolic alkalosis because they increase hydrogen ion excretion. E is not correct because opiates reduce respiratory drive and therefore cause respiratory acidosis. In our case, the patient has tachypnea. Thanks for listening.